Welcome, dear friends. Today we are going to learn about intrauterine drug delivery system. So, objective of this particular topic is that after completions, the students will be able to explain advantages, disadvantages of the intrauterine devices. Also, they will be able to explain development of intrauterine devices and their applications. So, vagina and uterus, they are the route for administration of contraceptives, antifungals, and antimicrobials. These are used for local as well as for systemic purposes. Oral contraceptive pills and intrauterine contraceptive devices, which are abbreviated as IUDs, these are the most effective temporary methods of fertility regulation. An IUD exerts its contraceptive action locally in the uterine cavity and continuously for a prolonged period without requiring sustained patient motivation. This contraception with an IUD is long acting and poses less of a problem with patient non-compliance. A recent survey indicated that IUDs, which are used by approximately 90 million women worldwide, have been found to be very effective means of preventing pregnancies. So there are two types of IUDs. The first is non-medicated and the second is medicated. The non-medicated IUD, it exerts its contraceptive action by producing a sterile inflammatory response in the endometrium by its mechanical interaction. The non-medicated IUD currently available for intrauterine contraception consists of a ring-shaped IUD, which is made up of stainless steel and plastic IUD fabricated from polyethylene or polypropylene. The medicated IUD, they are capable of delivering a pharmacologically active anti-fertility agent. Two classes of medicated IUDs are available: the copper-bearing IUD and the progesterone releasing IUD. Let us see the historical development of IUDs. The development of intrauterine contraceptive devices, it began in 1920s with the first generation of IUD constructed from silkworm gut and flexible metal wire. But there was a difficulty of insertion. There was need of frequent removal as a result of pain and bleeding and other serious complication, and hence they became obsolete. Then several plastic-based IUDs of varying shapes and sizes were constructed from various inert biocompatible polymeric materials, including polyethylene, polypropylene, ethylene vinyl acetate copolymer, and silicon elastomer. The development of a plastic spiral and a plastic loop opened up the modern era of IUD development. The contraceptive efficiency of these non-medicated plastic IUDs was reported to be proportional to the surface area of the device in the direct contact with the endometrium. That is, larger IUDs are more effective in preventing pregnancy than the small IUDs. Unfortunately, the larger devices, they caused more endometrial compression and myometrial distension, leading to increased uterine cramps, bleeding, and expulsion of the IUD. So, a T-shaped polyethylene device was later developed by Tatum to conform better to the contours of the uterine cavity. So, this is how the IUD look like, T-shaped IUD. So this new design was reported to significantly reduce the IUD related side effects of pain, bleeding, and expulsion. Because of its small surface area, it was also linked with the pregnancy rate as high as 18%. Recently, its good uterine tolerance has been recognized and has made this device the carrier of choice for the intrauterine delivery of contraceptive agents such as copper and progestin. This development initiated a new era of research and development for long-term intrauterine contraception, leading to the generation of a new generation of IUDs, the medicated intrauterine contraceptive devices. Copper-bearing IUDs such as copper 7 and progesterone-releasing IUDs such as progestasert thus evolved. Now let us see the anatomy of uterus. Uterus is a pear-shaped, thick-walled muscular organ and is suspended in the anterior part of the pelvic cavity. So in its normal state, it measures about 3 inches long and 2 inches wide. Fallopian tubes, they enter its upper portion, one on each side, and the lower portion of the uterus, it projects into the vagina. The uterus moves freely. Consequently, its position varies with the state of distension of the bladder and the rectum. The uterine cavity is normally triangular in shape and flattened anterior-posteriorly, making the cavity appear a mere slit when it is observed from the side. So this is the uterus, this is the cervix, this is the vagina. These are the fallopian tubes which are connected to ovaries at its ends. These are the fallopian tubes and these are the ovaries. And this is the uterus. So if you have a sideways view, you just observe this thing is the uterus. So the wall of the uterus, it consists of 3 layers. The endometrium, it is the innermost coat of the uterine wall, and it is a mucous membrane. It consists of an epithelial lining and connective tissue. It has got many arteries, and these arteries are in coiled form. Okay, so these coiled arteries, they are very important in the menstruation when the superficial portion of the endometrium is sloughed off. The next layer is the myometrium. It is thick muscular middle layer. It is made up of bundles of interlaced smooth muscle fibers embedded in the connective tissue. The myometrium is subdivided into 3 ill-defined intertwining muscular layers, the middle of which contains many large blood vessels of the uterine wall. It is this intertwining arrangement of the muscle that presses against the blood vessels and stops bleeding after the delivery of a baby. The innermost layer is the peritoneum. It covers the external surface of the uterus, which is then attached to both sides of the pelvic cavity by broad ligaments through which the uterine arteries cross. Now let us see the ovarian hormones and control of the menstrual cycle. The menstrual cycle is divided into 2 phases. The first 14 days of the cycle, it starts from the first day on which bleeding occurs, and this phase is called as the follicular phase. And the next phase is of the second 14 days, and it is called as the luteal phase. So during the follicular phase, estradiol is secreted from the ovary, and an ovarian follicle will enlarge and it will move to the surface of the ovary. Then ovulation, normally it occurs on 14th day. So in the subsequent luteal phase, the corpus luteum is very active initially, and then it starts to degenerate just before the next menstruation. So in both the follicular as well as the luteal phases of the cycle, the blood circulation continuously supplies the endometrium through the coiled arteries. So when the time of menstruation approaches, there is a reduction in the blood circulation in those coiled arteries, which supply the superficial layer of the endometrium. Followed by prolonged closure of these vessels, it results in a blanching of this endometrium. After a period of time, these arteries open up again and blood escapes through the walls with the formation of subepithelial hematoma. The endometrium is again regenerated from 5th to 14th or 13th day, and these all changes, they are brought about by estradiol. So in the subsequent 14 days, that is in the luteal phase, the progesterone produced by the follicular lutein cells in conjunction with estrogenic hormones in a suitable proportion builds up the endometrium for the reception of a fertilized ovum. Now let us see the copper medicated IUDs. So initially, in earlier days, D-shaped IUDs were used, but they caused pain and expulsion. So later, the researchers, they shifted to the T-shaped IUD. So if your T-shaped IUD, it is copper medicated, then that particular IUD is called as copper T. And this is a very common thing which we hear. Okay. So pain and expulsion rate was lowered in this case, and this might be due to the T shape, as it conforms well to the uterine cavity, which minimizes the distortion of the myometrium. And secondly, it can be attributed to the displacement and rotation of the T-shaped IUD inside the endometrial cavity, resisted by the 3 points of the contact between the device and the endometrial walls. So now if you observe this diagram, it is clear that this is the T-shaped IUD, and it is after insertion into the uterus, it gets completely fixed in this uterine walls, okay, and hence there is less chance of expulsion. But the rate of conception in this case was found to be 18.3%. So this low contraceptive effectiveness, it could be related to the relatively small surface area of the T-shaped IUD. So although it is moderately ineffective in preventing conception, the T-shaped IUD possesses useful features as a potential carrier for long-term intrauterine administration of anti-fertility agents. So a major first testing of this idea was initiated by Zipper. What they did, they wound the contraceptive copper wire around the dependent or the vertical arm of the T-shaped plastic frame. Further development of the concept of intrauterine contraception by metallic copper has resulted in the commercialization of a copper bearing IUD, which contains 89 milligram of copper wire binding around the vertical limb of a 7-shaped polypropylene plastic device to give an effective surface area of approximately 200 mm square. Now copper, how does it act as anti-fertility agent? Copper is known to be cytotoxic if present in sufficiently high concentration, and it enhances the spermatocidal and spermatodepressive action of an IUD. So many types of copper teas are available. Copper T 200, it provides surface area of 200 mm square, and copper T 30, it provides surface area of 30 mm square. Now let us see the hormonal IUD. The T-shaped device, which is made up of polyethylene frame, measures 32 mm in both vertical and horizontal direction. So there is silicon reservoir containing dispersed levonorgestrel or progesterone on vertical stem, and further enclosed in a sleeve of rate controlling membrane of ethylene vinyl copolymer. So it prevents pregnancy for up to 5 years by steadily releasing small amount of progesterone directly into the uterus. It works by thickening the cervical mucus so that sperm have more difficulty to swim through the uterus. For some women, it may also prevent ovulation from occurring. Now, this is an example of hormonal IUD. So you can observe here, this is made up of polyethylene, and inside this there is 30 milligram of progesterone microcrystals, and barium sulfate, which is suspended in the silicone oil. And above it is a layer of ethylene vinyl acetate copolymer, which releases the drug slowly. Now let us see the advantages. First, we'll see the advantage of non-hormonal IUDs. These are safe. They are effective immediately and highly. They can be used for long term, up to 10 years effect. There is freedom from having to remember to use contraceptives regularly or at the time of intercourse. It is cost effective. It can be, the action can be reversed very easily. The advantages of hormonal IUD is that after about 5 months, nearly all women they will experience light periods only. After 12 months, 20% of the women will have no periods at all. This is in case of menopause. And this can be used to treat excessive heavy menstrual bleeding as well. It reduces the pains during the periods. It may be suitable for women who approaches menopause as it provides effective contraception and can continue to be used as the progesterone component for hormone replacement therapy. Now let us see the disadvantages. First, we'll see the disadvantages of non-hormonal IUDs. They require a visit to trained physician for insertion and removal. Some risk of expulsion are observed within the first year. For some women, there is increased menstrual bleeding and cramping. Also, there is lack of protection against STDs, including HIV. The disadvantages of hormonal IUDs are there is irregular bleeding pattern in the early stages. Some women they experience backache for several days or weeks after insertion. Also, some women experience nausea and headache, and also there is a major problem of weight gain. So this was all about intrauterine devices. Thank you for watching.